My name is Carissa, and I'm going to go ahead and do a simulated lactation consultant. I'll be the provider, and today I will be meeting with a patient named Paulina. She is coming in with her daughter. Her daughter's name is Penelope. Penelope is 8 days old, and mom is a 30-year-old female who speaks English, who is a G1P1, who delivered her daughter via vaginal delivery with no complications. It should be noted that the patient lives in an area where the nearest hospital is 40 minutes away, and the closest health clinic is the health department, and that is approximately 49 minutes away. Um, the baby left the hospital at an appropriate weight. She was 3.8 kilograms. However, it should be noted that she has lost 9% of her birth weight, which I believe makes her 3.4. I think 9 or 10%. She came to the local community health care center, which is in a low income area. The patient is on state aid, and the patient is a single mom with no help from the dad. And she comes in with complaints of nipple soreness, difficulty and pain when latching, when initiating breastfeeding. And she says that she thinks her baby is feeding for too long. And so she's feeding for long periods of time, and she's concerned that her daughter's actually not getting enough, even though she's on her breast for 30 to 40 minutes at a time. I want to make sure that I note that at this health center where I'm meeting my patient, there is a room specially designed for moms. It's a room, it has like a large nursery reclining type chair. There is a desk for the us to put items or have pumps or to place diaper bags, stuff like that, so nothing's on the floor. There is a breastfeeding pillow. There is also a sink provided with soap and water, and the room is designed to make moms feel comfortable. They want to feel like it's a welcoming room. The room as it has a neutral color. It has a warm, inviting feeling. However, it is on the smaller side. There isn't a ton of room, like I said, due to the area that we are in and to the lack of resources that we may have. Some relevant factors pertaining to the mom include a breast reduction. The mom had a breast reduction approximately 5 years ago. She has no other chronic illnesses, no thyroid disease. Mom states that she's not diabetic and that she's otherwise overall healthy and had a healthy pregnancy. Mom doesn't take any medications except for a prenatal and a probiotic. Mom had an uncomplicated vaginal delivery. She did note that she had a low-grade episiotomy, but she did have normal EBL and a normal delivery overall. Mom overall looks healthy. She appears healthy, appropriate height, weight, stature. She does look tired, which is also noted to be appropriate, but she is in good spirits. She does have a good attitude and psychosocial. She's appropriate, she's calm, she's cooperative throughout our lactation assessment, or lactation consultant, I should say. Mom's goal was to breastfeed for 6 months. She wanted to at least get a full 6 months in, reassess at 6 months, and then kind of go from there. She did want to donate her milk if she was considered to be an overproducer. She wanted to make sure that she could give back to the community to moms who could not produce if she was able to produce enough to freeze and store and donate to a local, not so close, like an hour away clinic. Upon her breast assessment, mom has medium-sized breasts. She has scar marks that are noted but that are faded. They look like they healed or well approximated. She had a healthy and appropriate surgery. She healed well. Like I said, her scars have faded from her surgery. She is noted to have some abrasions and irritations to her breast, but there's no redness, no warmth, no pain that is noted or reported by the mom. There's no cracking or bleeding on the nipples. Her breasts at this moment are soft. They're non-tender, but her nipples are slightly flat. Um, the mom does report to me that her breasts can be rock hard in the morning, all of which she said started around, I believe it was the fourth or the fifth day. Some factors pertaining to the infant that um, uh, upon the baby's some relevant factors pertaining to the baby include that obviously she was delivered vaginally. She was a full term infant born at 39 and a half weeks. She had an APGAR score of 9. Um, the baby Penelope, has 5 wet diapers a day. She has 2 stools a day, and her stools are noted to be that dark green in color, with that sticky kind of consistency. Um, baby Penelope, is noted to have no tongue tie upon assessment, has normal tongue mobility, but does have a slightly, if you want to call it, softer suck. Baby feeds approximately every 2 to 3 hours, which is initiated by the mom. It takes approximately 7 to 10 minutes for the baby to latch, but usually she does, but then falls asleep not too long after latching and tends to stay on the breast anywhere from 30 to 40 minutes at a time. Some maternal assessment findings that we should note that could impact lactation is that the mom does report rock hard breasts in the morning, which that is indicative of engorgement. This could affect the transfer of the milk, how much milk is being given from mother to baby. Mom also reports some pain during latching and difficulty during latching. She rates her pain about a 7 out of 10. Says it's not like excruciating, but it is quite uncomfortable. The mom's nipple has a striae that is noted. When we assess the baby during the breastfeeding, the infant is sleepy, but awakens appropriately when stimulated, but falls back asleep not too long after that stimulation. The baby does take several minutes to latch and appears flustered and frustrated. When she has the inability to latch after 5 minutes, you can tell that she kind of gets a little restless, a little irritated, turns her head away slightly, but does have those cues that when she is latching, that at some point that she is hungry and she does want to feed at like that 2 to 3 hour mark. When the baby does latch, it is noted that the lips are tucked inward and that there's an inconsistency with the baby's swallowing. So there's not a consistent suckling sound. It is audible. You can hear that suckling. However, it should be noted that it is not consistent. It should be considered that the baby's having an ineffective latch, which is contributing to the baby not getting enough milk since there's not enough milk transferring to the baby to make the baby full and make the baby fed. The mom's milk should have fully come in by day 6 of being postpartum, and we are, I think I had mentioned that we are approximately, approximately 7 to 9 days postpartum. So she should have an appropriate milk supply at this time. The mom does report that she is pumping to keep up with her milk supply. Therefore, due to the pumping and the latching and the baby feeding off the breast, that her milk supply is regulated. She is continuing to produce adequately. However, we should take into consideration that the lack of stimulation of the oxytocin and the prolactin, that there could be a drop in her milk supply, and there's some other factors that we'll talk about as well. The mom also did report engorgement, which could in turn cause difficulty in latching since her breasts are rock hard, as she calls it. Therefore, it would flatten the nipple, making it difficult for the baby to latch. But when you do stimulate the mom's nipple, it does become everted. So it is out there and available for a baby to latch onto. Mom also states that she had a breast reduction surgery. That could be of utter importance. The ducts could have been cut. The connectivity can vary from patient to patient. If you cut the fourth intercostal nerve, um, that can be damaged and it affects the milk supply since that nerve is essentially providing the sensation to the nipples and is responsible for triggering um, that prolactin and oxytocin. Um, Also, it's also producing that letdown. We want to have that letdown so that baby, like I said, you can have a strong letdown or a soft letdown, but we want that letdown to be appropriate enough so that the baby starts to suckle and starts to have that sucking, gurgling sound when taking in the milk. Um, Ejection, the milk ejection can be really affected too with that breast surgery. Some women, when they have a breast reduction surgery, their nipples are moved technically, and some have their nipples that are left attached. With this being said, leaving the nipples attached is the best option that we can do that can occur for a mom, um, and that's up to the surgeon, obviously. But this helps to preserve the ducts, it preserves the nerves, it preserves the blood supply. But this is not always the case. So it would be dependent upon what happened during surgery for that breast reduction if those nipples were moved or not. If they are moved, the milk ducts can be essentially just severed, and nipple sensation is often decreased. There were some differentials when meeting with this mom that I could eliminate. We didn't think mastitis because there's not a lot of warmth or tenderness or swelling. Tongue tie, we did an assessment on the baby, and since the baby's assessment was normal, we were not considering a tongue tie to be the reason for the baby having difficulty latching and getting that full milk supply. Low milk production. We're thinking that this is unlikely because if we're considering it in terms of like how many days postpartum and how many days it takes for the milk to come in, mom's day 8 postpartum and milk is coming in by day 6. But the mom did have a breast reduction surgery, which can overall affect, like we talked about, the nerves endings, the milk supply, how much milk that baby is getting. So, we also want to really consider that there is a shallow latch because the nipple has pain, which that can in turn lead to poor milk transfer from mom to baby. The mom was noted to have some striae, so on her assessment, so the infant is on also the mom's breast for a prolonged period of time. That 30 to 40 minutes is quite a long time. Um, and that the baby did lose 10% of her weight. So we're really kind of focusing on that. There was striae, there was prolonged period of time on the baby was on the mom breast, and that the baby lost 10%, and we start to get concerned at that 10% mark. We did note upon assessment that the baby had an inward lips when latching, and we also need to be concerned about this as well. I want to make sure that during my visit with the mom that we figure out what we think the issue might be. We are leaning towards inadequate, like I said, milk supply, inappropriate latching, and that the breast surgery may have affected it, but we aren't 100% sure yet. So it is of the utmost importance that I teach my patient, that I talk with her, that I empathize with her. I'm going to meet with her. I'm going to say, I'm so sorry that you're feeling this way. I'm so sorry that this is happening to you. Give her some reassurance without reassuring her that everything's going to be okay, because we don't know that everything's going to be okay. In the fact that her wish of wanting to breastfeed for 6 months is going to be met. We want to be empathetic. We want to empathize with our patient. We want to make sure that we say that we're caring for, mom, not just mom, but mom and baby. We're gonna, see what we can do our very best, educate, make sure we have follow-up appointments, all these kinds of things. So we are going to We're going to be concerned with our patient. We're going to use simple language when speaking with them. We don't want to make them feel overwhelmed or stressed out. We want to provide them with visual demonstrations where we're having the actual mom and the baby latch in our office so that we can get a good assessment and representation of what is going on with that mom and with that baby and latching. We don't want to just talk about it. We want to actually see and visualize it. Um, and like I said, we want to make sure that we're teaching her, we're reassuring her, we're understanding her, we're educating her all throughout this entire process. We want to make sure that we use the teach back method. That is the best method that we can do. We want to ensure that my patient, is learning, that she's understanding, that she's comprehending what's going on. And I want to teach her in little increments and have her teach me back what I may or may not do with her. We'll talk about more about that in a little bit. I want to make sure that we take into consideration her culture and personal values, that that this is very important, that she wants to be a mom, that she wants to have a family, that we understand her views on breastfeeding, on like I said, what's most important to her, what she's looking for, what we're trying to accomplish during this lactation consultant. We want to be very like we had mentioned, empathetic and supportive during this time. This is more so like an assessment, and we're just going to kind of try to figure out what is going on and how can we help this mom and this baby. We want to encourage the mom that fed is best, no matter how the baby gets fed, whether it's through breastfeeding or formula or a mix of both. That, fed is best. We want a happy baby. We want a healthy baby. There is no right or wrong way to feed that baby, whether it is through breast milk or breastfeeding. The mom may have a hard time because she may be more so upset because she wants to have that encounter with that baby, have that relationship with that baby, of that breastfeeding experience, but it doesn't always happen, and that's okay too. We want to state that we are here for support. That reminder that she's not alone. We want to show her that there are support groups, there are other moms, educators. Show her that there are many different ways that we can get through this, and we want to provide her with her resources. So, what I'm going to do with this mom during this lactation consultant is I'm going to demonstrate and educate the mom about positioning and lactation techniques. So we want to talk about positioning, that we're going to support the infant's head and neck. That we're going to support the infant's neck and shoulders, not just the head. We're not just here for the head, but we want to have appropriate positioning. We want to have like a tummy to tummy alignment, mom's tummy with the belly's tummy supporting that neck and shoulder. That ear to shoulder hip needs to be in a straight line when we're holding that baby in that position. It's the cross cradle and the laid back position. We want to talk about early latch prep, that we want to have about approximately 1 to 2 minutes of how we can soften the pressure to release any areolar swelling that there may be and that engorgement that is there. We want to express some of that milk prior to latching to soften the nipple. This helps to soften the nipple, put some flavor and some milk actually onto the nipple to get that baby to latch on, to get that baby interested. We want to keep that baby interested in latching and continuing on that nipple. So getting the nipple prepared is important. We want to have the infant's nose to the nipple. We want a wide mouth. We want to bring the baby to the breast. We don't want to bring the breast to the baby. Like I said, we want to bring baby to nipple and get going. We want wide lips. We want cheeks to be full. We want to have the areola visible above the nipple, above the upper lip. We want to tell mom that pain should not be there for very long. It should decrease after 20 to 30 seconds. We want to get that baby to appropriately latch. If the baby does not appropriately latch, we need to break that seal, remove the baby, and then latch the baby back on. And we want to help a baby if they have like a recessed chin. We want to have like a laid back position. Gravity's on our side, so we want to have the baby laid back, so then have the baby being closer. And we could put like, like the boppy pillow or an added towel to the shoulder for cradling. We want to pay attention. We want to let the mom know to pay attention to the feeding cues and the frequency. We want early cues. We don't want late cues with that baby. We want to make sure we get that baby on that breast sooner rather than later. We don't want to wait until they're crying, until they're really overworked and stressed out and having difficulty latching. We want to have educate on the how many feedings we were going to have, every day. We want to have anywhere from about 8, 10, 11 feedings every day in about 24 hours. We want to put the baby on the breast for 10, 15, 20 minutes per breast, depending on, which one the baby's interested in. We can go left, we can start right, but we do want to obviously try to keep that even. We want to make sure, like I said, we switch to the breast. We don't just want to do one. We're going to start to get lopsided and have unequalness. We want to educate the mom on nutrition and hydration. We want to teach the mom that she needs to have balanced meals and snacks. She wants to snack throughout the day. She wants to stay hydrated, stay fed. She needs to eat protein. She needs to eat vegetables and fruit. She needs to stay, at her best. She needs to drink lots of water, 2 liters a day, if not more, especially she's like burning all those calories with breastfeeding. We want her to continue to take her medication. We need to make sure all medications are safe. We need to do a full history of her medications, make sure that, it's not crossing that barrier and is harmful to the baby. Prenatals are healthy and safe. We want her to continue those to get all those vitamins that she needs. We don't want her taking any herbal supplements. Those can also affect the productivity. We want to teach the mom about storage. What can we do? What can we do for the mom? Let's see, and educating her about like how long can the breast milk be out for, how long can it be stored for. Refrigerator can be in there for 4 days. The room, if it's at room temperature, it can be in there for 4 hours. She can store that milk for 6 to 12 months, but on the earlier side is the best. We want to also teach the mom about pumping if she is going to pump. We want her to pump for 10 minutes after the session. We want to, make sure that we're expressing all that milk. We want to talk to the mom about any complications that could arise, about engorgement, low milk supply, any nipple pain, any signs that are really important. So, warm compresses before we feed her, cold compresses after, frequent breast emptying, either by the manually expressing that milk or by pumping. We want to make sure we have a deep latch. We are frequently feeding. We don't want to feed the baby if she's too sleepy. We're not feeding her, we're not getting enough milk in her. We're not feeding her effectively. We want to make sure we have a good latch, a good suck, a good feed, and a good removal and then pumping afterward. We want to teach about what can we put on the nipples for comfort. There's linoleum creams. Typically with engorgement, you can do the Cabbage Patch leaves, but we want to make sure that we keep that breast comfortable for that mom so that she can continue to feed appropriately. And then, if the baby's not gaining enough weight, if the baby's having very few wet diapers, anywhere less than 6 diapers, she really needs to call her pediatrician. She needs to get that baby in to be seen. We need to the mom needs to notify her doctor if she has a fever, if baby has a fever, if the mom's having warmth, tenderness, severe engorgement, extreme excruciating pain, any type of like infection that comes out of the breast. We want to make sure that we're educating her on that. And then we're going to want to see this mom within 48 hours. Recheck with her. We want to make sure, we're probably seeing her every day or two, most likely every 2 days to make it more, what's the word, so that the mom's not, getting overtired by coming in. We don't want to see her too fast or too little. And we want to do weight checks. We want checks. We want to continue to observe for that latch. Want to make sure, are we having still a good latch? Is the latch getting worse? Are we getting better? What do we need to reassess our assessment and figure out what's going on so that we can get baby healthy, keep baby healthy, keep mom healthy, keep baby fed. Like we said, fed is best. So we want to also make sure that we're not judging the mom for her um, what's going on, that it's okay that her baby may not be being fed at this time, that we're going to work on it. We want to be empathetic and not condescending. We want to be helpful and not harmful in any way. Um, and that is it. We'll see how that goes with mom, and then we'll readjust and adjust our plan of care as necessary.